Welcome to this first case of our new series of instructive cases in hematopathology. So my name is Wolfram Klapper. I'm hematopathologist in the Department of Pathology in Kiel, which is a consultation center since decades and well known from the 70s and when Professor Lennart was working in this place establishing the Kiel classification. In this series of cases, we would like to share with you how we approach the diagnosis of certain lymphomas and hope that you find this information valuable. So our first case is a very young child that was suffering from cervical lymphadenopathy and stridor, and we received a biopsy from a cervical lymph node, and I would like to share this biopsy with you. So this biopsy is a small biopsy or coming in fragments, as you can see here. You see a little bit remnants of germinal centers in these biopsies, but in many areas, germinal center and the expected structure of the lymph node has been gone, is vanished. What you see in these areas is already from the far a kind of starry sky picture and then monomorphic infiltration. I will enlarge that a little bit more of lymphatic cells. And in these lymphatic cells, they are relatively small. It's difficult to distinguish them from lymphocytes, but their chromatin is more open than the one of lymphocytes. That makes it a little bit um, easier to see. What you can see here is you look at these small cells here, which are the very dense chromatin dense cells, which are probably lymphocytes. So the vast majority is only slightly larger, but overall the chromatin is more loose. You see the macrophages, and some of them contains tingible bodies in here, so that this is at least coming close to a starry sky pattern. It is for me not a real starry sky pattern because the cellular infiltration that you see here has not the cohesive picture that you see usually in Burkitt's lymphoma when we call this a starry sky pattern. So this morphology with this dense chromatin and narrow rim of cytoplasm, I can hardly see it at all in this H&E stain. This is typical morphology of a lymphoblastic lymphoma, a common disease in young children. And to confirm this diagnosis, you need some stainings. The most important one needs to be applied first. This is the staining for TDT. And TDT, as you can see here, stains a lot of these cells, but not all of them. Nevertheless, TDT is a very precise marker to distinguish precursor cells and mature cells. This positivity you see here is already, for me, sufficient to prove that we have here an infiltration by lymphoblastic cells, so precursor cells, immature cells. And the next step in the diagnosis would then be for me to check each line of differentiation. So we are always staining all these lines. The first thing we stain is CD3, and you see here CD3 is faintly positive on these cells. It's not possible to distinguish membranous from cytoplasmic staining by immunohistochemistry. We know this since a long time, which is possible by flow cytometry, not by immunohistochemistry. What you can see here is a remnant of a germinal center, interestingly, which are some of them are still be seen. We will see this in a second in the staining for CD19. So this is this positivity for the T cell lineage. I will now stain for CD19 to see if there is B cell differentiation present. And you see that the infiltration, the blastic cells are negative. What we see as positive are the germinal centers here, sometimes even disrupted and a little bit colonized. Important for me is also to check for myeloperoxidase as a third lineage, the myelopoietic differentiation, and I don't see any expression. These are just normal small granulocytes being positive in the infiltration. So this are precursors. These are precursor cells, which are TDT positive, and they express the T cell marker CD3, but they do not express markers of other lineages, neither CD19 nor myeloperoxidase. The only thing we do in subtyping this disease is staining for CD1A, which you can see here as being partially positive. This indicates that this is a cortical phenotype developed. I also recommend to stain for Ki67 in these cases, to see that we really have an unambitious high proliferation. Ki67 rate is usually above 50%. Here it's even higher. So in my opinion, this is a typical case of a lymphoblastic lymphoma, and my diagnosis would thus be precursor T lymphoblastic lymphoma with a cortical phenotype. What to consider if diagnosing or before signing out such a diagnosis is always that you need an unequivocal proof of the precursor cell phenotype, which is usually by immunohistochemistry the expression of TDT. If TDT is negative, but you see something that you consider a T cell lymphoma, it's very difficult to prove that these are precursor cells. What in the TCL lineage could be considered as alternative markers of precursor cell phenotype is expression of CD1A and CD34, but in my opinion also to some extent a multilineage phenotype, so expression of B and T cell markers or myeloid markers, like as far as these markers are lineage specific. That's also why I think the second point is important. If we diagnose such a lymphoma, even if we find positivity for a certain lineage, like CD3 expression indicating T cell lineage, we always stay for all the other markers by a very limited panel, as you can see here, by CD3, CD19, and myeloperoxidase to rule out any multilineage phenotype. Subtyping this lymphoma is not clinically relevant currently. However, we recommend to stain for CD1A because this indicates the cortical phenotypes and seems to be something that is easily applicable to these lymphomas. What to keep in mind before signing out lymphoblastic lymphomas: there are conditions containing precursor T cells, so TDT positive T cells in children. And these are, for example, the hyperplastic thymus. So, but this thymus is or should only be considered if you're in a mediastinal localization. There's a very easy test to rule out hyperplastic thymus simply by staining for cytokeratins, which are absent in a lymphoma. Of course, you can also detect other features of thymic anatomy, like the zonation. In cases you have any doubt, you should go for clonality testing and show that, in fact, this disease, the lymphoblastic lymphoma, is clonal. It is a really difficult situation if the patient presents with a mediastinal mass, which is a very frequent presentation of lymphoblastic lymphoma of T cell lineage. In these cases, you should carefully go for cytokeratins and also clonality. Thymoma is very uncommon in young patients, whereas T lymphoblastic lymphoma is a common disease in young patients and children, so also clonality testing might help. You should have in mind that benign proliferation of TDT's precursor cells can occur under benign conditions. There is a benign lymphoproliferation of these cells in lymph nodes, sometimes massively tumor-like appearing in histology, but these cells are relatively low in proliferation. The patients show an indolent course, so they suffer from relapses, but the disease doesn't become more aggressive and in fact is not really making the patients critically ill. It's a very difficult disease, but that's why we include Ki67 on our staining panel to always make sure that we have a high proliferation as expected in T lymphoblastic lymphoma. And then you should also have in mind that scattered single TDT positive cells occur in benign hyperplastic tissue, especially of young patients. And one example that particularly shows TDT positive cells is the morbus Castleman. This is the considerations we have in a case like in a case where we sign out such a diagnosis. And I hope that you find this information valuable, and see you next time.